Hello, everyone. Welcome back to another interesting episode of Tea Talks Tuesday. So, we are here today with an interesting speaker. Dr. Sai Mala ma'am is here. And coming to today's topic, the topic is overview of public health nutrition in first 1,000 days of life. Okay, infant mortality rate and maternal mortality rate are the two major indicators of public health. So the first 1,000 days are crucial to child's growth and development and future outcome of health. And first 1,000 days are decided by the maternal health, that is right from the conception onwards. Thus, first 1,000 days are of prime importance in improving the public health and the development of nation itself. So today, Dr. Sai Mala ma'am is here to share her experience as a part of public healthcare system, and ma'am is head operations at Fitterfly Health Tech Private Limited. Ma'am is here, and today for a change our speaker would like to introduce herself because of her varied experience. So I would like to pass on to Saimala ma'am, it's over to you, ma'am.
Thank you so much, Mayuri. Well, I said I would introduce myself because probably usually whoever a nutritionist said would want to work, I probably worked in several of those fields. So, well, I started my career as a guest faculty at the Allahabad University. So, because my husband was working there and he was posted there, so I was with him. So, I joined there and then continued teaching for a certain time. Then I took a break when my children were young and I needed to be at home with my children, and the timings were not matching. I couldn't take up a long career. Then my serious career, which my in terms of seriousness is about 8 hours of working in a day, minimum of 8 hours of working. That I took up at Care Hospitals, Hyderabad, somewhere in 2006, where I worked for 2 years, almost 2 years. Then I moved on to work at Hyderabad at the Agricultural University, where I did some research on millets. So it was a World Bank project. So there was a storage studies also taken up, and also I used to make products of different millets take to NIN, where there were a panel who would decide the taste and so on. Then that was of course a short stint. Then I joined MST Pharmaceuticals, where I did patient management. That was uh, patient support remotely, which was one of its kind then. So it was more on diabetes and metabolic diseases, and it started in a very small scale with some 5, 6 people. But then I worked there for 8 years. By the time I left, we managed more than 50,000 patients across India in 13 different languages. We had supported them, and the team expanded from the 5 to more than 90. So that was the time that I decided that I was doing some research on numbers. I was doing some analytics on the data that I was receiving from this patient support group, whether there was improvement in their outcomes, did their HbA1c reduce, did their blood sugar reduce, was there a change in the diet pattern, did it cause any change? So while I was looking at this number, so I thought I would take up some course in data analytics. So I did a course from ISB, Indian School of Business at Hyderabad, a 1 year course on data analytics, which made me more familiar. Though as a nutritionist, we would not require as much, but some playing around with numbers, statistics, and different methodologies that are involved with it. So with that, I thought I would work somewhere where a nutritionist can fit and understand some data. And that is when I joined Care India at Patna, Bihar, which is an NGO. It is an international NGO, and then it had a understanding with Bill and Melinda Gates Foundation. It was running the project of Bill and Melinda Gates Foundation. Now, Bill and Melinda Gates Foundation had a tie-up with government of Bihar. They had a memorandum of understanding, which we call as MOU, with the government. So the BMGF promised to provide technical support to government of Bihar to implement health and nutrition projects all across Bihar in 38 districts of Bihar.
Wow.
So it was almost 100 million project which there were a long time. So we were about 2,000 people working in different areas. So the Care India team would support right from the health secretary till the ground level, which was Asha and Anganwadis, at the hospitals and the ICDS system, both the systems, so that they would improve the health outcomes of women and children. The focus was on women and children up to 2 years, and that is how I thought I would speak about some experience of mine of these 1,000 days with you. Later, I worked there for almost 6 years, and then I'm currently working with Butterfly Technology, which is in digital therapeutics. So now I'm all into understanding how a continuous glucose monitoring system would work and how we can give a customized diet plan based on it. And that is a new era in itself. So maybe sometime else we can talk about digital therapeutics.
Definitely, definitely.
But today, then, like I would like to talk about my experience in Bihar. But basically, uh, um, the work there is of twofold. One is somebody who would understand and do research and understand how the health and nutrition scenario is across the state, share this data with all the stakeholders involved, which is the government, the ICDS at different levels, and other NGOs like WHO and UNICEF who are working in Bihar. So that is one part of the work. And then there is an implementation team which would bring out the action points and help Bihar government to plan the strategies which can improve the health and nutrition of women and children. So there are two different divisions of it. So I was part of the research division where I would understand the nutritional scenario of the whole Bihar, of all the 38 districts of Bihar, and share this data with the government. So nutritionists play a role. So I just thought I would tell you of how a nutritionist can play a role in NGO. So they can be part of the implementation team where they can implement the different programs an NGO would strategize and plan for it. Or they can be part of a research team like this and survey teams, which actually bring out it's like nutritional surveillance. So we understand what is happening uh, on different indicators. So, well then, let's start. I'll just share my screen.
Yes, ma'am.
So now, how did the 1,000 days come? So it's about a pregnancy, which covers around 270 days, followed by the first 2 years of life, and together they form the 1,000 days. And why 1,000 days? Because it is a critical period of growth. Just think of it. Life starts with one cell, and that one cell, by the time the child is born, we expect a minimum weight of 2.5 kgs, which is 2,500 grams. And a cell, is not even a milligram. And then, as life progresses in 2 years, in 3 months, or they double their weight, and the growth continues. And that is the magnificence of life. And then it is most critical because every cell that is building up with the nutrients that the mother is supplying to the child. And later, after the child is born, through different feeding methods, the cells grow, and that is how growth happens. So there is no need for me to emphasize to the nutritionists how important this period is, and hence we'll see what can happen. Now, if there is poor growth during this period, there are some irreversible changes that are happening because some of it can never be changed. So it's better to take prevention is what public health is all about, because we understand what is happening and then we think of strategies that can prevent diseases or prevent some scenarios. Well, now public health, as I said, it includes health, it includes hygiene, it includes nutrition, and it includes disease prevention, to be precise. And then, so which means health, that about it is currently, if you call public health, it is about hospitals, how the treatment is there for both the mother and the child. then say immunization services, then family planning services, all these will be part of health. Then the nutrition part is usually taken up both some part by health and some part with the ICDS, where continuously together these two systems try to create community awareness, support counseling to the mother, and then bring about a change in the way people think based on wherever the need is. And then there are services which are planned so that whatever gaps are there in the system, they can be fulfilled. Now, these are some of the ICDS, they say six aspects of ICDS, which cover supplementary nutrition. It can be giving some take-home ration or feeding the mother or the child. Then preschool education, which is between up to say 5 to 6 years. Then health and nutrition education, immunization, health checkups, and also referral services. So the first thing that when you enter a public health nutrition, they talk about indicators. And that was one question that I could never ask when I attended my Care India interview, because I never knew working at hospitals and in hospital environment, what were public health indicators. The word indicator itself was new to me. Of course, I was selected because I answered all the questions in statistics, and then it was a huge team to manage. So I had some people management experience, so that is how I was selected, not because I knew public health. So what I'm telling the young people in the group is that if at all you want to start, you can start anywhere. You can take gaps based on your career. Being women, there might be certain scenarios which would call for it, and then you can learn new things at any age. Because I took up my career when my daughter was in ninth standard. That is when I joined Care India. And when I joined Patna, they were grown up and they were in different hostels. So that is where I thought I will explore and work at Patna. So health indicators basically means that based on the outcomes, you think of certain ways to measure success. So those are called as the indicators. So when do you say that maternal during pregnancy, women that the government is able to achieve all that a woman would need? So some of them, I'm not going into micro details, so I'm covering basics. So these are antenatal checkups during pregnancy, which means you understand how, suppose there are 100 women at a place, say in Anganwadi center, the jurisdiction, how many of them received at least 4 ANC visits during their pregnancy? So this is one of a health indicator. And how are the 4 defined? One in each trimester, and in the third trimester, we expect at least 2. Then, did the mother receive their first ANC during their first trimester? And why is it important? Suppose a woman has to take iron and folic acid capsules, say for 180 days, which is the government mandate that they want to supply for 180 days. Then they should have a 6-month period before their delivery. So if they register themselves and they talk to an ANM about their pregnancy quite late, then there is no scope for them to take all the tablets that a government would want to give or a woman would benefit from. So supplementation and other nutrition indicators have to start from right. So one of the important indicators is, did they register for their pregnancy and did they complete their first ANC during their first trimester? Then did they receive a TT injection? Some are expected to receive 2, some are expected to receive 1. So did the woman receive 1? So as part of ANC, of course, there are different parameters. Did the blood pressure get checked? Did their weight, was their weight measured? And was it adequate? So based on it, the ANM who is measuring it will have to counsel the mother on the care that they have to take. Suppose the weight gain is not as per the norm, then the ANM or the ASHA is expected to talk to the woman on what to do so that it is appropriate, what to eat during the period, why they should be talking to a woman on why should a woman take IFA, how many they should take, when they should take. So all this aspect will come as part of the counseling that the frontline worker is expected to do with the women who are registered with them. By registration, I mean they're pregnant, they go get their name registered. So this is the part of counseling that will go to the women. And then there is also, when they get their ANC checkup, they get the IFA tablets, they get albendazole, they're supposed to get whatever supplements they have. And apart from these nutritional aspects, the FLWs also counsel on birth preparedness. By birth preparedness, we mean whether the woman is ready to go to the hospital, did they identify the hospital, did they identify the mode of transport to the hospital, did they arrange money, if there is an emergency, do they know which is the higher hospital they have to go? So these are part of the birth preparedness, so that in case of difficulty at delivery, the woman is fully prepared and knows what to do. And that is part of the birth preparedness. And institutional delivery. Institutional delivery may not be a problem in Telangana, because when I saw the indicators, it was around 97%. But at Bihar in 2015, when I went, 30% of women, to be precise, 28% were delivering at home. And this indicator moved in the 5 years that I stayed there, and it came up to some 20%, which means 80% started going to the hospital. So when such data is shared with the government comes up with plans. So they started incentivizing the ashas for bringing a woman to the hospital for delivery. They started incentivizing the mother so that they would also get receive money when they go to the hospital for delivery. They arranged free hospital, free transport, that is free ambulance of pick and drop for the person. So these are some of the government policies that come up when we do such research and tell them this is how the numbers are. And then CARE as an NGO, what it started doing, it started identifying pockets where the home delivery were higher. And then they started working with the FLWs there, so that, and the health personnel there, so that those people are motivated.
Ma'am, can you please unmute yourself? Yes.
Yeah.
Yes.
So they started training the nurses at and the doctors at the hospital, so that the reception is better. Right from planning how many, based on the population, how many deliveries are expected, how many trays should they have in ready, how many beds they should be there, and what is the skill set, how to handle emergencies, what is the quantity of drugs that a hospital would need. So these estimates were made based, and then this is the technical support that an NGO would give the government, so that the government is ready and take it up, and more number of deliveries can be had safely by these women. So then some of the maternal health nutrition indicators are whether the women took 180 iron and folic acid supplements and deworming during their pregnancy, and proportion of women who were anemic, and then maternal dietary diversity. So maternal dietary is here. Now, when we take a recall of the patient, we take a complete history of what the person would, what a woman would eat. And as the person, we estimate the calories, we estimate the carbohydrate, protein, and content, and then we try to see how much the woman would require. But in a public health scenario, you have to remember that it is done at a population level, and such individual indicators are very difficult to assess and give also. So what is usually done is that we, data collector would take the recall of the person, whether the food contains a cereal or a pulse, for example, whether it is a yes or no in the previous day's diet. And then we map based on what the person said. The person might say, I had roti, I had sabji, I had aloo curry, and I had tea. So they would take, then there is a cereal, there is some vegetables. There are some vegetables. They ask what sabji it was, and they suppose they say it is yellow pumpkin, then vitamin A is chosen. Otherwise, it could be other vegetable. And that is how the complete recall of one day is taken from sunrise to sunset, usually, not a 24 one. And then we estimate how many food groups the person had. And then the indicator for dietary diversity is if the women had at least 5 food groups of the 10, then the woman is supposed to meet dietary diversity. And these are all international guidelines. FAO, if you want, you can read up as to how the team arrived at these 10 food groups and why they decided as 5 as the cutoff. They said at least a minimum of 5 groups. If they say, then it will be a balance of several groups. So that is how the assessment is done. And these are some pics from my, work. There is a village health and nutrition day that happens, which is once a month for every village. And people come there, they get their antenatal checkup, they get IFA, they get immunization for their child. So that is one place. And if you see the women with the 3 children on the right side, you can see even a tab there. Down, that is my data collector who was collecting data from the mother who recently delivered. So you can see some group counseling pics also. Well, this is one of our surveys which we try to do for women, where adolescents, pregnant, lactating, and women in interpregnancy are there, which includes interpregnancy means those who had one child and who aspire to have one more, and the gap between them. So what we see here is high rates of anemia. We see that every 7 out of 10 pregnant women and 8 out of 10 lactating women were anemic, and severe anemia is almost in 50% of the women. And then comes BMI. So BMI, now we all work with people who have higher BMI, but there for the first time I met women who had a BMI of less than 18.5, and that is as high as 50%. And these pregnant women during pregnancy, during our field visits, we realize that they eat less during pregnancy actually. They say pachta nahi hai. And they also concentrate on a easy delivery, especially at home. They do not want a C-section. So they try to keep their weight under control, eat a little less, so that they feel that if they eat more, the baby is going to grow more, and then the delivery would be difficult and would be C-section. So these are some of the illogical or thinking that people have, which each NGO and the government try to work with the people. They're difficult to remove because they're ingrained for a long period of time. But that is somewhere somebody has to start, and usually there is improvement over a period of years. So this is about dietary diversity. Don't worry about the colors. It is just to say that over the years we do cross-sectional studies. So this is survey of 17, 18, 19 and 20 for 4 consecutive years. And what you see at the bottom end is says the number of women who were interviewed, which is around 30,000 each year. So these are women who have a child of 6 to 12 months. So say, and look at the way the food is eaten. And then you see the dietary diversity, it is around 20%, which means out of 100 people, only some 20 to 22 women have at least 5 food groups in a day. So when we share such data, you know where the lacking is. So people come up, government comes up with different strategies. They say kitchen gardening, they send seeds, they give eggs, they give multivitamin powders. So that is a sort of uh, what we had done. So share the data, and government comes up with different plans. Now, this is something which I saw. This is again a pic from, I visited a friend in Vijayawada, and I was surprised to see all this given to a lactating woman. In Bihar, this was unheard of because the woman actually wouldn't receive much, but the government of Andhra Pradesh seems to have a very good monitoring system, because the Anganwadi worker came, gave all the things. She had a pic with the women, which she would share in the app. So it looked like a very good way of doing the work where a mother would receive. But what would happen is this would go into the family food. And it is not that only the woman would eat, the whole family would share it. And then we are not sure that the mother received it. Now, I asked my friends to share what is happening in Telangana. They said that there is an Arugya Lakshmi program where there is a meal that is served at the Anganwadi center, where the mother would come and have there. And there is also an IFA which is given then and there, where the woman has to take. And then there is regular weight monitoring and also the counseling services. Now, this is another pic. The center pic is shows both Annaprasan and Godh Barai. The woman who is having a red chunni is having her Godh Barai. So the Godh Barai is also a government initiative. There might be a different name for what is the schemes of Andhra Pradesh and Telangana, where a pregnant woman is asked to come, and the Anganwadi worker talks to her about different food groups, gives her IFA, gives her some take-home ration, and also talks to her about family planning that she has to implement after the delivery. And this particular Anganwadi worker decided to combine both Annaprashan and Godbarai. Annaprashan is nothing but when the child reaches 6 months, they're all invited to the Anganwadi center. The Anganwadi worker cooks food, shows them how to demonstrate how to cook the food, wash their hands, when to wash their hands, the method of washing their hands, and then how to maintain hygiene, how much to feed, what to feed, and the counseling goes on. So what I showed you previously, this is a cross-sectional study. By cross-sectional study, it means that we do at one point of time, maybe on different years. Is this a serial cross-sectional study? That is what we call, because we did on consecutive years at one particular point of time. And something like Annaprashan or Godbarai divers, we go and observe it. So it is called an observational study, where there is no questions asked to the people. There is a set of questions to be filled up, and people, data collectors, observe what is happening there and fill up the forms, and we estimate how good or how efficient or where the gaps are in it, and again we share with the government. So you can see another lady on the top giving food. So now there is a huge variation in the way Anganwadi worker could actually do the Annaprashan, because you see the pics are quite different in the way the display is, the talk is. So that is what we try to tell the government as to how they have to standardize the process and get it done. Now there is one more pic of a woman feeding the child. Now that we say is a very common practice, but then the mother really does not know whether the child, how much the child had. So what is usually recommended is that the mother should be given, and during the Annaprashan givers, they usually give katoris which are 100 ml, and then there is a mark by saying if the child is 6 to 8 months, then the mother is supposed to feed at least 2 times in a day from that katori of 100 ml quantity, which will include minimum of at least 3 to 4 food groups. So that is how the nutritional indicators are measured to and see, and a rough measures are given to the women who can follow as well as to the Anganwadi workers, so that the minimum nutritional requirements are met and the child does not move into wasting and stunting. So now when we talk about growth, child growth, now you can see for yourself, when does the child have maximum growth, right? In the first 3 months, it is 200 grams per week, which is almost 800 grams per month. Whereas as the child grows older, if the child is 1 year, then it is only 2.5 kgs for the whole year. And in 3 to 5 years, it is only 2 kgs per year. So you see that the maximum growth is happening till their second year, till their first year, and then to the second year. And that is why, suppose you have resources and money, where do you want to spend? That the government decided that it should focus on the first 2 years of life, because that is when maximum growth is happening. And similarly, you can see the length. In first year, the length is 25 centimeters, whereas in the third year, it is only 9 centimeters. So there also you see that the growth happens to the maximum extent in the first and the second years. Well, now what to do with child nutrition? You can measure whatever the food the child is having, or you can measure the growth, because food again will convert into growth, that you all know the link between them. So both are done. And this is one of my favorite graphs, which is from the National Family Health Survey 3. It is an all India results, where you can also see that stunting, as you know, is height for age, underweight is weight for age, and wasting is weight for height. So you see that as the child grows older, the wasting, which is usually acute malnutrition, that comes down, because the child starts eating and they start putting on weight. Whereas the stunting and underweight growth, they increase a lot after 12th, after the child reaches 1 year. And this is one more reason why all the public health nutrition is focused on the first 2 years of life. Because once stunting sets in, it is an irreversible change, and the growth spurt again happens only in the teenage, and then the brain development and other things hampered. And hence it is very important that the complementary feeding, which happens in the 6 to 12 months, and later feeding is given a lot of importance. So, what are the core indicators for assessing infant and young child feeding practices, which are called commonly as the IVCF practices? So, one is early initiation of breastfeeding. We see how many women are put to breast within 1 hour of delivery. So, within 1 hour, because the child gets colostrum, and also skin to skin care, which will reduce hypothermia. And so, that is one of the indicators that is measured in public health. Then exclusive breastfeeding under 6 months, because the breast milk contains all the nutrients that the child would require. And at the same time, what happens is there is a practice of giving water, and that water can be from a spoon, a bottle, or any other method, which can be unhygienic and can cause infection. So a lot is emphasized on exclusive breastfeeding, which means without water or without any other, because at times people have the habit of giving gripe water, people have the habit of giving sugar candy at the end of it, and different communities have different practices. Then continued breastfeeding even after the child starts complementary feeding up to 1 year. And then timely initiation of complementary feeding. It is defined as initiation of complementary feeding between 6 to 8 months of age, where they received solid or semi-solid or any soft food if they received on the previous day, then the child is supposed to have received complementary feeding in a timely way. And then there is also a minimum dietary diversity for the child, which is again slightly different, where we say there are 7 food groups which are there. Vitamin A rich fruits and vegetables are combined to one. For maternal, there are split into two. And similarly, the fruits and vegetables are here combined into one, because that is where most of the micronutrients are coming from. And nuts are a separate group in women. Here it is 7. And a child is expected to have received minimum dietary diversity if the child receives 4 or more food groups. Then the other core indicators are, did the child receive minimum meal frequency? That is, at least 2 times a child should be fed if the person is 6 to 8. And as the age increases, the number of feeding times increases. And also about 100 ml each time. I already mentioned about the Katori measurement that is there. Some NGOs also give marked ones, cups, so that the mother knows exactly what is fed. So there is something about the frequency, and minimum acceptable diet is a combination of frequency and dietary diversity. In short, it is about quantity and quality both put together is minimum acceptable diet. So that is how the nutritional indicators are measured in children, whether it is breastfeeding or later. And some of them get iron rich and iron fortified foods also. So this is some of the data from my past experience, which around 76% or some around 80% receive timely initiation of breastfeeding, which is within 1 hour of delivery. And if you look at a split of where the delivery happened, what happens is the private delivery, most of them are C-section. And when it is C-section, they can't start feeding the child within 1 hour. And hence this indicator goes down. So if you remove the C-section, then the indicator goes up. So you have to look into those micro details. And then if there's nothing that the NGO can do with the private sector, but then with the rest, they can talk about why it is important. And then, as I spoke about water, we did once the survey was conducted in May, and then this indicator of exclusive breastfeeding dipped drastically. And the next year, we decided to do in winter. It usually is in this time of the year, October to December, and the indicator went up. So then we realized that there is a seasonality associated with it. The seasonality is because the women give more water during summer, because they feel that the child needs more water during that time. And as winter sets in, they feel that it is cold, and especially in Bihar, it is very cold. And hence they do not give water, and hence this indicator improves. So similarly, we saw some in dietary diversity also. I'll share with you. So this is initiation of complementary feeding. Despite all the graphs that I showed you on wasting and stunting, to see that only 50% or half the population actually start giving food to the child at 6 months. They say that the child cannot digest, the child cannot eat, and despite all the measures, the indicator just moved, some say from 48% to 58%, but there has not been drastic. So you can understand how difficult the behavior modification is with rural women. And hence different strategies, they keep changing it, they keep planning different things, but then there is still a long way to go. And that is when some of these initiatives like Annaprashan Divas come up, where the women are called. So when a child is feeding, when a mother is shielding a child, the others who are not feeding will get inspired and they might also start feeding the child. So that is how it is. And because of these, the stunting rates and the wasting rates are continue to be high, and that is why public health nutritionists are concentrating to bring this down. And then I talked about minimum dietary diversity, getting 4 food groups out of 7. And you can see that in the 6 to 8 months, it is as low as 9%. And then in 9 to 11 months, it is slightly higher because the child is growing up and they can start eating something. And it is around 20%, which is still very low, which means, okay, we are not getting, we are not taking a complete recall of the, complete assessment of carbohydrate, protein, and nutrient. But this itself says that they're not getting a balanced meal. For a balanced meal, we want some carbohydrate to be there, some protein to be there, and some fruits and vegetables, which can include some micronutrients to be there. And so these three, when they are there, then they would have met their dietary diversity. So so dietary diversity is nothing but a quick estimate of how good or balanced the person is having. So here also we found seasonality, because usually they take 3 food groups: rice, or roti, and some milk and some dal. So getting the 4th food group is the most problematic. And when we did it in summer, again, this indicator was also high because some mango pieces were given to the child. And because of the mango, the indicator went up, and there also the seasonality plays a role. Well, to summarize, how does public health work in the first 1,000 days to bring about improvement in maternal and child health? Is to have the ashas and frontline workers to visit the homes of pregnant women, talk to them, registering them, giving iron and folic acid, calcium, doing their ANC and a proper ANC, and then give take-home rations, and probably whatever the schemes are of the government to implement them. And then when it comes to birth preparedness, it is ensuring that the mother has a safe delivery, and then provide whatever is required for the mother to have that safe delivery. Then postnatal care is one of the most important thing in post delivery, apart from the nutritional practices, is the identification of danger signs. So if the mother can quickly look for identify the danger signs and go to the hospital, then it would be of great help. I forgot to tell you about the SAM study. I just want to show you a pic. Now, whatever pic I think you're able to see on the right. On the right is from my, again, a field visit. We were doing a longitudinal study. I spoke about observational studies and cross-sectional studies. This was a longitudinal study. So in a cross-sectional study, we get the prevalence of anything. Prevalence by means at a point how many people are suffering, say, from stunting. So that is prevalence of stunting. Suppose that in this longitudinal study, we get the incidence of an event. So incidence of severe acute malnutrition. So we followed up, say in some 30 villages, we followed all the children aged 0 to 5 years for a period of 1 year. So every month there would be growth monitoring, and there would also be a questionnaire on to assess their health in the past 1 month, whether they felt sick, what did they do about it, what was the kind of sickness, whether it was diarrhea, fever, acute respiratory infection, which could be pneumonia. So the person would assess all these health indicators, what the women did, whether they took to the doctor, whether they did home remedy, and what was the duration of the illness, whether it was recurrent. This child, when I interviewed, was having severe diarrhea for 10 days. The mother typically gave a history that the child would be sick for 10 days, the child would be normal for another 10 days, again would fall sick. So it is like the whole digestion of the nutrients was severely affected with severe diarrhea, and that too recurrent diarrhea. And whatever, and usually the parents stop feeding during that period because they think that the child is having diarrhea. And that leads to the so-called vicious circle of malnutrition that we read, that disease is causing malnutrition, and malnutrition per se, they become very prone to infection, and they're getting recurrent illness. So that way, I mean, that is how this history of this child was. And during that 1 year period, what we actually wanted to understand was, one, antecedents of a person, how a child would go move into SAM, how a normal child, because every month we would be going and monitoring, you would know when there is a change in weight that there are moving into malnutrition. So we understand what happened in the previous 2-3 months, and then assess the antecedents that are causing a child to move from a healthy state into a acute malnourished child. And also we understand the incidence. By incidence we mean how many new cases of SAM are we detecting, because a child can get a recurrent SAM, they can get after 2 months, they can again go into SAM. So we were trying to see the first time they become, that is called incidence, or how many new cases we are getting. That will help the government to cater and understand at a population level. They have these NRCs, that is the nutrition rehabilitation centers at the government hospitals, where this child and the mother would get admitted, and they were given supplements, they are given health treatment till the child recovers and puts on weight. Until their appetite improves, they start taking food. They should move from supplements to normal foods, and then the child and the mother are discharged. So that is a longitudinal study we did. So this is how we did, as part of research, different types of studies to understand what could be done, and how many should the government cater to, what are the schemes that the government could come up, and if the government is doing, then they would support it. So this is briefly what government tries to do in the first 1,000 days. And typically the status is, this is for research purpose for you all to understand. Suppose we want to reduce stunting, what could be done? So we want to ensure that the mother gives adequate food, which is, as we discussed, quantity and quality, follow hygiene, because of the child, there is no hygiene maintained, then there is chance of infection. Then early detection and treatment to the child. This is very crucial. It can be as simple as the child stopped breastfeeding. The mother should not neglect, or it is 1 day of diarrhea, that mother should not neglect. They should take immediately to the doctor and start treatment, because that is when they can prevent the child from going into a severe state of infection and thereby malnutrition. So these identifying them is also part of the counseling that is provided to the mother. So for the mother to do this, what should the process be through ICD? Then there has to be visits by frontline workers, and the frontline workers should have told how much the child should be fed, how much and what type of food should be given. And then growth monitoring is very important, because as a mandate they have to measure the child's weight every month, and they have to measure the height every quarter. So whether such thing is there, and take home ration, it can be for the child, it can be for the mother, and then reinforce these messages. For that to happen, what are the inputs that somebody could give from the government is to identify the issues, have a standard protocol, something like Andhra Pradesh, where the monitoring is very strict and they ensure that the mother is actually receiving, and training of these people and to how to communicate, easy way to explain to the mothers, and the necessary logistics to be there. Logistics can be as simple as, if the Anganwadi worker has to create that event of Bodhvarai or Annaprashan, they require some at least 500 rupees to organize it. So is the Anganwadi worker receiving it on time? At the is there a protocol of what should be procured and how it should be displayed? So things like that. And then documentation and review. So this is what is the cycle in research, what we call as input, the process, the output, and the measurement, and getting the outcome. And all of it can be measured to the several studies. It could be observational, as I mentioned, cross-sectional, or any method where we understand the whole process. And it will be a feedback loop for the system to improvise on the inputs and then improve the process so that the outputs and outcomes are achieved. So that is how a typical research cycle goes on to get an understanding of how the nutritional scenario is in public health. Now we have this is one of the most talked of survey in public health, which is the National Family Health Survey. In short, it is called NFHS, and this was the last survey. It happens once in 5 years, and it gives state level and district level indicators. So several indicators have already shown, and the government decides certain districts they prioritize if the indicators are extremely low. So those low performing districts, they at times pick up some 100 in the whole country and focus completely on them so that the indicators move and the nutrition and health status of the women and children are improvised. So let's have a glimpse. I don't want you to have a look at the numbers, just see how the indicators, as I said, I never knew what indicators were before I went there. So I thought you could have a look at how indicators are defined, measured, and there is nothing statistical about it. Don't think it are numbers. It is just a simple proportion. How many achieved something? What is the denominator into 100? Something which we were doing from school. How many marks did we get in the unit test? And divided by, if it is for 25 marks, 12 by 25, and then convert it into 100. It is as simple as that. You don't require a degree from ISB to do it, but you need a understanding of research and bent of mind to say and look at the numbers and see what the numbers mean about. So here you see institutional delivery. As I said, Telangana has no problem. It is 98%. Bihar, it is only 80% when I left in February. And then, but you see public and institutional births are only 50%, whereas it is slightly higher in Bihar, because here more people are going to private organizations, there more people go to still government hospitals. Now women age 20 to 24, marriage before the age of 18 years. So there are some general indicators also. It is as low as 16.7%, and Bihar, it is just the opposite. It is more than 80% get married before the age of 18 years. They usually have a child and the family is complete by the time they're 19 or 20 years old. And then these are the other indicators of child feeding practices. As we discussed, it is a breastfeeding, it is about feeding practices, stunting, wasting, and of course BMI and anemia. So this is how the general indicators of nutrition look like in public health. So that's it. Any questions? I'm happy to answer.
Thank you so much, ma'am. It was a great session. And Harita Shah ma'am has few questions. Ma'am, you can unmute yourself and you can ask the questions. Harita ma'am.
Okay, thank you for that. Sai Mala ma'am, thank you so much for giving us a glimpse into public health, because we certainly are not exposed to public health in any ways. And as I was hearing to you, I did put up a few questions. The omnipresent concept of bringing them to Anganwadi was definitely a good idea. You can capture them. I just was interested in understanding what food is actually provided to the mothers to improve their nutritional status.
That actually, it is so nice to hear from you after a long time. And and then for this, see, every state has a different mechanism to do that, and usually it is a cereal pulse combination with a lot of green leafy vegetables, and there is a protein content defined by the ICDS which goes to the mother. That is the protocol. Now how, and if it is a take home ration, as I said, which is followed by Bihar government, and it is not a hot cooked meal, then the actually the mother receiving it is very little. It is as low as 10% in Bihar. But if you have a monitoring system the way I showed in Andhra Pradesh, then there are likelihood of it is defined. But nutritionists and ICDS define actually the protein based on the ICMR guidelines.
Yeah, I mean, in Bihar only, when you were monitoring the program,
they had take home ration, Harita. So they had some rice and pulse alone with some soya and egg that was provided. which was way below what the mother would require. So they thought of giving some nutrients in the form of fat, and they thought of different products, but ultimately nothing took off till date. If there is some change in the last 6 months, I'm not aware of.
Okay, because I think what they're doing in Assam, where the chief minister is very, very particular, is they are included spirulina based chickies, which they're giving it to SAM children. And I think they're also giving it to the mothers, where
Yes,
they have to consume it then and
yes.
there. And probably the, in what the mother actually gets is much better. So the mother, does she have to come to the Anganwadi every day, or
In
once?
a hot cooked meal concept, wherever it is implemented, the mother is expected to come for lunch, have that meal, take the IFA, and go. In Bihar, as I said, it was take home ration, so it was not included. Each state, the pattern varies.
Okay. So, also my another question was on breastfeeding. Is there a way where you identify the mother looks extremely underfed and malnourished, and if she continued to breastfeed, it would only actually add to her burden? Is there any such concept?
Usually, the Bihar mothers are able to feed the child, and the proportion who are not able to feed are very little. Actually, they continue breastfeeding till their second year of life, despite whatever BMI they have. So that was not a problem. There was a minor section, or as low as 2% who could not breastfeed their child. This is what the data said. We looked into it, but we hardly found anything. Maybe because it was a rural environment where it was getting done. But at times we see that breast milk stops for some people at a very early stage, and then they have to shift to other methods.
Yeah, if you see that, if you see in urban population, that seems to be one of the biggest concerns, that they don't get milk and what galactagogues to take. So how do, and these are women who are well fed. So how does it work in, people who are
Maybe
actually?
the timely initiation of breastfeeding and their continuous breastfeeding, that is what is probably helping them, because they do not rely on any other method. As I said, it is as high as 80% continue till the second year. So that is where that is not an issue. Giving water, there is an issue. So handling them and telling them not to give anything except breast milk was the strongest message that was going, rather than you have to exclusively breastfeed.
Yeah. And I know that research wise it may not be possible, but do you look at the composition of breast milk will be very different if the mother is not eating well or she's not getting that diversity that you're talking about?
Yeah, that is when the complementary. That is why you don't see that graph which I showed of NFHs. It doesn't start at zero. It is already showing that it is starting around 20%, which means at birth itself there is some malnourishment. And that is one thing of real concern, and that continues. So when you have some certain things to prioritize, the government prioritize on what is the maximum impact that could happen with the effort that they can put, and then they concentrate on bringing up the infrastructure and the other aspects, and the other population of 10% who are not able to achieve will actually take a backseat.
Mhm. So that means even if the child, if, even if the child is exclusively being breastfed, there is a possibility that they're still underweight and not growing to their best potential. Is that what you're saying?
Usually in the 6 months of age, they're usually okay. But the malnourishment and the growth faltering is happening mostly after the 6 month. There, because one thing, the child starts eating other food, and the chances of infection are more because of the environment there, and also because there is not enough supplements that are dense and are given. Things like adding 1 teaspoon of oil to the katori of food that the child eats is actually going to improve the density of calories that would go in. So at times, though it is present at home, the mother is not adding. So there are different aspects to it. Not just on the quality of breast milk, but on the other hygienic aspects also of the child.
Yeah, completely understand that. And you also meant about, how dietary diversity can be used as the assessment tool where you can't do in-depth recalls.
Yeah.
So that's interesting that we could use that as well in our, regular practice as well. Only question that I had is roughly minimum 7 food groups you're looking at, but there are days when people are taking it, not taking it daily, but once or twice a week they would take it. So would you still include that as taken?
No, the indicator says in the last 24 hours. So we expect them to take on a daily basis. So the indicator says that in the last 24 hours, if they have taken, they have taken. So that is where a public health is about the population level estimate. When it has to be individual level, we expect them, suppose a nutritionist following them, then and you want to use it in the OP, then probably you'll have to take a recall of all the 7 days. But it is difficult when a person may not remember what they had. So this is an easy way of doing, and we can also tell the patient that you look at these 5 things, at least these 5 things should be there in your meal so that you know that it is come.
Yeah. Yeah, that's good actually, because when students do it, or generally you want to look at diversity and don't want to go into real detailed recalls, looking at dietary diversity also helpful, right? Great, Saimala. Thank you. Nice
Thank you,
interacting with.
Hanika.
Maybe the next time I'll ask Janki that she should ask you to present on your current area of work from
Yes,
Butterfly, and that will also be extremely useful for all of us.
yes. Now that is the most happening thing around.
Yeah, that's the most happening thing. Wellness seems to be booming right now.
Wellness, and thanks to COVID, that people are moving into digital platforms and looking at improving their health outcomes.
Yeah. So we're looking forward for that also from you. Thank you. Over to you, Mayuri.
Yes, ma'am. Sai Mala ma'am, can you please stop screen sharing? Yeah. So we have a few questions on Facebook. Manishweta is asking, is there any limit to how many months to breastfeed, like minimum or maximum? Generally said, after 1 year, mother's milk does not have some same nutritional values as before.
Yes, so they are expected to continue breastfeeding, but it does not mean that they should not give complementary feeding. They should continue with complementary feeding, and as you see, the number of feeds also increase. And as the child actually, if they come to a regular feed, say around say 1.5 years or so, then automatically their intake of breastfeeding would usually come down. I also have Priya, my colleague who worked with me. So, Priya, if you have anything to share, you can put in the chat box because she is an expert in pediatric nutrition.
I mean, she can unmute and she can talk to us if she's here. And Purnima Roy is asking, like, ma'am, choline-rich foods, is it necessary during pregnancy?
Which one? I didn't get
Choline,
you.
choline,
Prebiotics.
choline, CHOLINE.
Okay. I don't have any information from public health perspective on this. So, even I have to read up on this.
Yeah. Okay. And ma'am, as you said, along with the complementary feeding, the breastfeeding has to be continued. But when kids, they get used to for the breastfeeding, and in spite of that, if they are not taking the complementary feeding, how do we, what measures can be taken?
So usually they talk about a set time and environment that has to be created, and there is including them into the family gathering. So all those means that the mothers find it very difficult to implement, but they have to find the time to be with the child and feed. And actually, that is one more problem that is causing, because when there are working women, especially
Right.
those who go to the fields and who work in brick kilns, what we found is that the child is left at the care of an elder child, and
Yes.
then there are issues that are happening. So yes, it takes time, and all of us faced it when we had when the children were young, and maybe now in future I'll take care of my grandchildren, and that struggle continues. There is no one answer to it.
Right. And also, ma'am, like as the seasonal thing is coming in and the water content, definitely, in the summers, they try to give the water more. And if the kids are below the like 6 months old, even then, is it recommended or not? Like how, like,
So the
will,
gynecologists are not recommending, WHO does not recommend, because they
yes,
say that breast milk has enough water content, all the nutrients that it is supposed to be there.
yes,
And it is continuously, there are some guidelines that is every 2 hours the child is fed and the child is actively asking for it. And so those are some of the ways that the mother can know whether the child is being fed properly or not.
yeah. Okay. Audience, any more questions? You can just post it in the chat box, or you can just unmute yourself if you are on Zoom. And ma'am is here to answer your doubts and clarify your questions. Mm, it was a great session, ma'am. Varied, as you said, like varied experience, and almost 6 years, ma'am, in this.
Yes, from
Um,
2015 to 2020, I left in Feb, only this Feb, 21.
Okay. Very huge experience actually. And as you said that continuous glucose monitoring, which is the current thing, which is there, we are definitely, we would definitely invite you back on Tea Talks and we'll definitely arrange a session. And as Haritama was also asking for this, we'll definitely do this. Audience, yeah, we are here for another 5 minutes. We'll just wait for another 3 to 5 minutes. And if you have any questions, you can just post it. Ma'am is here to clarify. I think Janki ma'am is not online. She missed the session. So yeah. So I would like to convey my vote of thanks to you, ma'am, Dr. Sai Mala ma'am. So thank you for being here on Tea Talks and giving us such a varied, such a huge, I'm sorry, a great session and enlightening us with all the necessary details of the first 1,000 days in public health sector. And thank you so much for being here, ma'am.
Thank you, Mayuri. Actually, it is the pleasure is all mine because it made me go through all the work that I did in the past 6 years. And so it was a review of it and I really enjoyed it. And looking forward to join you again. Thank you so much.
Thank you. Thank you all. See you next Tuesday, same time, same place. Bye for today. Thank you, ma'am.